It's a great pleasure to introduce Dr. Patricia Musolino from MGB in Boston, and she will speak about microvascular dysfunction and neurodegeneration and effects on gene therapy. This is again an example how our microvascular imaging biomarkers can be used to guide clinical treatments. Patricia, please introduce yourself and share your screen with us. Patricia is joining us virtually.
It's a pleasure to be remotely here, and I wish I was able to make it to the meeting, but I was not able to coordinate with the rest of life and other demands here. But I wanted to take an opportunity to really walk you through some of the longest journeys before Cercare was Cercare, and the work that we've been doing through an academic development that led to this amazing software and company now that is providing clinically available tools for very needed biomarkers and diseases. So I'm going to walk you through several projects we have had over the years. I'm a vascular neurologist, critical care neurologist here at MGH, and I study genetic and non-genetic vasculopathies and leukodystrophies. So today I'm going to be telling you about some of the work that we have in rare diseases. This is veering from the common diseases such as a stroke, which we have also used some of the Cercare capabilities to do differentiation of lesion progression and outcomes, as it was presented earlier on. But the disease that I'm going to present today, I think a lot of you are very familiar because of the field of expertise and because we call you all the time to try to get us a little bit of a hint when we are looking at a patient with an MRI looking like this. These are just T2 and FLAIR images. And of course, there's a lot more context clinically and in other sequences to help with the diagnosis. But at the bedside, a lot of the time, this is what we're doing, is we're calling the expert of the expert or who we think could know about this particular disease. And this is just the slide that I will use coming back in the presentation just to talk about ultra rare diseases like mutations in the actin gene ACTA2 that are only like 60 patients in the world, to things such as a small vessel disease and Hall radiation. Col41 a lot more frequent than ACTA2. And I will dedicate a lot of the work on how I got to work with microvascular perfusion imaging using the Cercare suite in the first disease that I was initially started to work, that we did gene therapy. Is now FDA approved, and which has published the entire cohort in the New England Journal of Medicine last month. Now it's December. And that disease is X-linked adrenoleukodystrophy. So something to keep in mind, and for me, that I'm a vascular neurologist, is that there is no development, degeneration, regeneration without normal microvascular environment. And that's because your stem cell niche postnatally depends highly on the dependence of vessels, and that's where they also sit in the subventricular zone and around the radial glia. So important to vascular function, and anything that we can read out of the vascular function is that it also helps us understand what is happening to this niche that is so necessary for development and degeneration and recovery. So let me tell you about this disease. Is X-link. The deficiency of ABCD1 leads to a very long-chain fatty acid elevation because the peroxisome is not able to process them. The MRIs of these boys, the women do not develop the cerebral form that I'm going to be talking about, are normal at birth. There is a pre-symptomatic phase. They start with characteristic typical lesions in the spleen of the corpus callosum, very small, and they propagate, centrifugate in a centrifugate manner across the white matter. And when we see contrast enhancement, that is the classic butterfly description of X-linked adrenoleukodystrophy in the neuroimaging world, and this is now changing as we have newborn screening and we have much earlier lesion diagnosis. We know that the blood-brain barrier disruption marks the rapid progression of the disease with basically a vegetative state or full loss of neurological function in less than 2 to 3 years in these boys. And the onset, as you can see, happens most commonly in childhood, but it can happen throughout the lifespan of these patients. We do have treatments for this disease. Now we have a gene therapy approved by the FDA, but before that, we have hematopoietic stem cell transplantation from allogenic transplants. And we knew that the window for treatment is very early on. We have a scoring system that you might be familiar called LESS score or LOES, depends on how you spell it. and that is an anatomical scoring of 34 points. And we know that transplant can work with LOES scores below 11. In other ways to show the disease, this is one of our patients in his karate practice who did not know that he had the disease in the family or he was an ABCD1 deficient carrier. And unfortunately, the first symptoms in his case were running into the walls because of alterations of visual pathway and hyperactivity and attention deficit. And this is only 8 months later. And he unfortunately had an advanced lesion even when he started doing his practicing here that led to him being cortically blind, nonverbal, unable to ambulate independently. And unfortunately, less than a year later, he succumbed to the disease. With Dr. Rapalino, one of our neuroradiologists, we took on, for the first time, Bruce Rosen was my mentor for my research at the time and said, what about looking at this disease and the blood-brain barrier in more detail? And we have DSC perfusion imaging, and we took on that. And the first observation was that the cerebral volume was decreased ahead of that rim of contrast enhancement in the lesions. And that treatment in red here was correcting that cerebral volume of microvascular dysfunction ahead of the restoration of that blood-brain barrier. And it could also predict where this lesion was looking and going. We expanded this work at the bench, and I'm not going to talk about this, but we basically dove into the question, how does ABCD1 deficiency alters blood-brain barrier? And we know that inflammatory cells to get into the brain have to cross the endothelial monolayer in the brain, and there is several different interactions. You can zoom into that. We studied several biological and molecular markers, and we basically conceptualize it as, and this is thanks to Kim Maritzen and Bo Hansen here, I hope present in the room. We were able on our brain publication to also show a little schematic of microvascular flow. And now that we have all the red blood cells with the oxygen extraction, as it was presented before, we use the MTT, so the variability of mean transient time, that we call CTH, to determine changes in the adaptability of the microvascular function. And then we use the K-app, which is the constant of permeability, which happens when the more interaction between the white blood cells and endothelials are possible in this disease. Is something that we know biochemically and also through assays. And that leads to the migration of these inflammatory cells into the brain. So I don't have to talk to you about what is perfusion, CBF, and MTT, but I always think about the main mechanism the brain has to adjust metabolic demand is homogenizing capillary blood flow. And that in our readouts, CTH is a decrease in that value. And of course, you're also familiar with the oxygen extraction equation, and whether a capillary has heterogeneous flow or homogeneous flow determines the maximum capacity of that oxygen extraction. So we basically quantify MTT variability, that is capillary transient time heterogeneity here, and K-up using the Cercare perfusion maps. This is Dr. Arne Lauer, also a neuroradiologist in University of Heidelberg now, but at the time postdoc here in Boston. And we first found that the patients with a deficiency had an increased heterogeneity of flow. And then we also found that this was higher in the areas of where the lesions are most frequent, such as the splenium of the corpus callosum compared to the central semiovale. And not only that, this increase in heterogeneity of flow, meaning microvascular dysfunction, was highest at the times that we see the top incidence of this disease and blood-brain barrier disruption, and that pattern in development was not present in control MRIs. In other words, we were able to find in patients that we follow longitudinally, these patients get MRIs every 6 months, once you know the disease in the family, to try to catch the lesions in very tiny, diminutive manner. And when the blood-brain barrier is disrupted, that's when we indicate the bone marrow transplant or the gene therapy. And you can see here how KF and OEC and CTH are high, while your T2 is not able to show you a lesion in the splenium of the corpus callosum. It's only 6 months later that we see the T2 hyperintensity. It's more than a year later that we see a T1 post-contrast enhancement in this patient. So allogenic bone marrow transplant is using a donor that has the ABCD1 gene normal, and getting the boy that has the disease in the brain with contrast enhancement, myeloablative chemotherapy to make room in the bone, and giving this stem cell infusion, hoping to have them engraft and then becoming myeloid cells that migrate to the brain and become part of the microglia. We knew from compassionate use of a bone marrow transplant that patients treated with low scores less than 10 had a much better survival than those untreated. And this is kind of the mechanism that we hypothesize. It's still in the hypothesis level, and we only have very little evidence that this is the mechanism, but that's what we think. And then the reality was that we were able to read out, this is the T2 lesions progressing over time. And after transplant, you see the T2 lesions, of course, do not change much, but the microvascular dysfunction is much more wider than the T2 change, and is also much more responsive to bone marrow transplant. This is also published in a much more detailed way. A very big challenge for bone marrow transplant, and why less than 10% of the boys receive this treatment with this disease, is the lack of an available compatible donor. And the outcomes are much worse when you don't have it. And here is the different ethnicities, and this is from the registries that we have currently. So that was what led to the development in France, in fact, of the first gene therapy using an HIV retroviral virus to put back the ABCD1 gene into the same cells of the kid, the CD34 cells that we apheresis after we stimulate the bone marrow. In this case, we use a LNTD. This was led by a company called Bluebird Bio, and Dr. Eichler was the primary PI with Dr. Williams. And then we did a follow-up 2 years later and expected the same, at least the same outcomes that we had with the bone marrow transplant. The preliminary results of the 17 patients were published initially, and now just last month, a couple of weeks ago, the final cohort with 50 patients, 30 something in this publication, were published. And this is basically what we saw. The treatment and the natural history are, as we were hoping to see, beneficial, and the treatment can halt the disease progression. Here is in images the T2 lesion, and what would have happened without treatment. And here's the contrast enhancing lesion. You can see very subtle enhancement at baseline, and then the disappearing of that contrast. And this is usually what happens in a 2-year mark in this disease. This is, in other words, in the lowest scores, and this is a very flat curve. The disease has almost exponential growth in the first 12 months of after the diagnosis. And all of this was possible because of the engagement of the community. You can see here a family with an older boy that is affected and severely neurologically involved, and this brother that has received the gene therapy, which has likely halted the disease and has now a normal neurological development. So we went ahead and tried to see if Cercare perfusion imaging could read out the effects of gene therapy, and what could also tell us in terms of mechanism of how the white matter is being restored. And the first observation was, of course, the volumetric analysis showed that the lesions acceleration, that is the normal progression of the lesions, flatten, that is decelerate. And we saw that that correlated between T2 lesions with the treatment in gene therapy, but also in bone marrow transplant. So in red, bone marrow transplantation, in blue, gene therapy. We also compare the amount of vector, the amount of viral copies in the cells that we give to the patient. Those are in green, they're called vector copy number. And that's kind of like drug product, the dose of gene that you're getting when you're getting the drug. And these are the vector copies in the cells of the patients in the periphery over time. So we knew that at least a certain level was necessary, and we did a correlation between T2 lesion growth, and we saw that correlation between drug product and the rate of deceleration of those lesions. And in fact, we were able to mark a threshold that is necessary to optimize the production of this cell gene therapy to enable an arrest of that disease. Moreover, we saw patients that have all they needed to have contrast enhancement at enrollment, and some of them at 30 days already started to efface it. Most of them at 6 months have effaced the contrast away, but as you can see, many of them have recurrence of contrast enhancement. But the contrast was very different, and we were puzzled about, what does this mean the disease is active? Does this mean that the patient is going to progress? So we took the MGH cohort, and this is also published in the same Nature Communications paper, and we look at what is the contrast enhancement between patients that have recurrence of gadolinium and not recurrence. And then we ask, is the K-up different in these patients? And what we basically found is that both gene therapy and bone marrow transplantation have a normalization of that alter increased blood-brain barrier permeability as read by K-up, which is more sensitive than T1 post-contrast, and that the levels corresponding with self-arrested disease when you were treated, and they were predicted of the treatment response. And here you have the correlations between white matter integrity by FA and T2 lesion growth based on K-up and the change in that microvascular heterogeneity. We went beyond that in using some of these maps and other formulas. We were able to also demonstrate that the entire white matter showed improved microvascular function and architecture. And moreover, we saw that these effects, the permeability being normalized here on red, in the normal appearing white matter in blue, and in the lesional white matter, was a process that was prolonged over time and sustained, which is the effect that is long lasting from the gene therapy. And that this K-up was also corresponding with this capillary heterogeneity being normalized. And we went on to try to understand, do we see that effect in the cells in the periphery? And the answer is not really. And we only have one patient that received bone marrow transplant that we had brain, and we were able to demonstrate that this is a control microvascular in the cortex, and you can see a pericyte and endothelial cell expressing ABCD1. That's normal. This is a patient with the disease without any expression of ABCD1 in green. And here you have a patient that has engrafted best here perivascular cells, probably myeloid cells, but here very clearly pericytes and some endothelial cells that are from the donor. So this effect in the microvasculature is possibly produced and provided by this CD34 pool of endothelial and other precursors that can engraft into the brain. I'm going to leave to very quickly tell you that we apply the same Cercare maps in perfusion to another clinical trial that just ended a week ago. The press release is about to go out today or tomorrow, that has met primary endpoint, which the aim of using an oral drug to slow down the disease, the cerebral progression. And the drug is capable of, similar to gene therapy and bone marrow transplant, to slow down lesions. The patients have much smaller lesions than most patients in the historical bone marrow transplant, but very comparable to the gene therapy cohort. And when we compare the effects of volumetrics in leriglitazone, which is this drug that I'm talking about, and bone marrow transplant and gene therapy, we saw that the effects, at least in the first 6-month intervals, which is the data that we had available to the analysis at this point, were comparable. And when we look at the RCTH or CTH, we also saw that the patients that were on leriglitazone were differentiating themselves, were normalizing that microvascular heterogeneity compared to those that were not treated from a natural history cohort, also at MGH. So there is many diseases that can cause white matter dysfunction from microvascular dysfunctions. Many of them are monogenic, and there's several of them that we have been putting into the pipeline now to see if we can detect white matter microvascular alterations. But this is also relevant because these diseases also lead to vasculopathies of larger arteries and stroke, and of course, a degenerative disease of the type of vascular dementia. So let me bring you in 4 slides to some of this data and what it's looking like. This is just preliminary. Whole brain radiation in the white matter. This is much more common to see white matter degeneration after whole brain radiation. We study with Dr. Dietrich a cohort of medulloblastoma patients that received whole brain radiation early in life, and we saw that there was a higher risk for those to develop microbleeds later, years after the radiation. And those that were on antiplatelets primarily have the highest risk. And this is the distribution of those microbleeds in that publication. This is published in Neurology. And we asked, could we predict which patients are going to develop the microbleeds in those areas versus those that do not, but earlier than when we see the development, so sooner after the radiation. And this is what we found in very preliminary assessments. At the time It says K2, but this is a K-up because it's done with the Cercare software. And we saw that pre and post radiation, there was a change in this permeability that is readable with Cercare and is not readable by contrast enhancement or any other sequence in MRI. Another disease that we currently have in vivo genome editing in development for it, ultra rare disease, terrible disease, childhood strokes before 6 years of age, and all of them with white matter degeneration with this kind of cystic-like lesions, perivascular spaces. And another disease that we are also developing gene therapy for called 4A1. And we knew from studying them more systematically and with very limited data, as you can see, that the white matter volumetrics is not progressing. So it's not going to be our biomarker. That the vessel diameters, yeah, they change, but they're all very early on changing. So not necessarily our best biomarker. But when we look at the same variables, K-up and CTH, we did find both in abnormal and normal appearing white matter very severe alterations in these patients, even when not having symptoms. So we are trying to develop therapies that can be also read out earlier before we see clinical endpoint to know that we have a therapeutic effect. So in summary, we have plenty of evidence that says ABCD1 deficiency in ALD alters brain endothelium and the permeability of the blood-brain barrier, that this is developmental and is trackable and visible with perfusion imaging users Cercare software. And moreover, that correction of hematopoietic cells, either by gene therapy or bone marrow, can be also read out by the Cercare perfusion maps. And I think this is a very strong biomarker and highly need that we could be using for determining patients at risk or different risk stratification in patients with degenerative disease, such as Alzheimer's. And just to remind everybody that 80% of Alzheimer's brain in the bank histological analysis have vascular disease, and we have very little understanding of how and when to track it. But we are at hand, we have tools at hand to do this now. So I think we should be thinking about what is the possibilities of using these markers to really do what we're doing with PET CT, for example, for amyloid biomarkers of Alzheimer's, but to really tackle a much earlier pathophysiology of the disease. With that, this is my lab, and this is a little bit of here is still in the academic times of Kim and John in Denmark, and this is Anne Borser and Arne Lauer, two are strong collaborators in the ALDE and the perfusion imaging work. With that, I think I'll stop.
Thank you very much, Dr. Musolino. Thank you, Patricia, for the outstanding presentation showing how the microvascular markers can be used in innovative ways in the clinic and in your research. So thank you for that. If there are any questions for Dr. Musolino, please ask. And here in front, I think Shannon.
Thank you very much for a very nice presentation. I would like to ask you whether you have any experience with multiple sclerosis, the new advanced maps and multiple sclerosis. Some patients progress despite for stationary MRI, and perhaps these maps could show something more.
It's a very, very good question. We initially used a small cohort of MS patients when we were looking at the cerebral volume with the Cercare maps. And we did find, and it's published not with Cercare, but with DSC perfusion and DCE perfusion, that cerebral volume in the areas where lesions appear and progress or expand is decreased. And it's usually 4 to 6 weeks before you can see any changes in a structural MRI. So I haven't seen since, this is a long time ago, this is around 2016, haven't seen since a comprehensive systematic study. And I would say one of the limitations in more common diseases is if the indication doesn't have contrast and gadolinium in the MRI clinically, then the DSC perfusion or the DCE perfusion is hard to get in a systematic way. And this is what is been happening in our stroke patients, because we are not longer doing contrast infusions in stroke patients in MRI. We use CT perfusion, an MRI only for structural and DWI. So, and at most ASL, which I don't like for white matter, as you could imagine. But it's work that is needed. I think it's a very strong and potent biomarker. The problem is feasibility will require that these patients get systematically contrast-enhancing MRIs, which is okay for MS patients, it's okay for tumor patients. Not all patients will have the same sequences. I'll say one more thing. DSC is a 2-minute sequence. We have put it in every single clinical trial. It has not extended our protocols. We give the contrast bolus. For example, for ALD, we need to wait 8 to 10 minutes to see the parenchymal leakage of that T1 post-contrast. So we have that time to acquire the other sequences, and that's where we acquire. The first one we acquire is DSC perfusion. DCE is a lot more involved, and it has much more time of acquisition. That's why if you give me a choice, while there is a strong work in the neuro-oncology literature on DCE, I will still prefer DSC. I think it's potent enough to do this work.
Thank you very much, Patricia.